Mannion here, teaching you guys about the importance of imaging. Amazing person. Please, Paddy, tell us a little bit about yourself and what you do so people can understand why you're here.
Okay, hi Hannah. So I'm a vet and a radiologist. So I'm slightly unusual in that I mainly do outpatient imaging. So I see patients for imaging and then they go back into their primary practice. I've done that for a long time. I've been a vet forever, ancient. I've got a whole array of my own animals. So we currently have 3 dogs, 2 cats, 2 ponies.
Wow.
So I kind of understand the whole owner aspect of things too.
Yeah, I had a lovely conversation with you about a year ago, and I think I was having a bit of a struggle with Cam, and you just gave me so much confidence and hope, and it was fantastic. Actually, you got me out of a bit of a, oh God, this is hard work. Lovely Lynn, join us. Hey Lynn. So
hello.
We're going to do something a little bit different today. We're going to be doing a slideshow, which is the first time we've tried this. So fingers crossed. Paddy's going to lead. I'm just going to be pressing the control button. So if it seems a little bit disjointed, it's because poor Paddy doesn't have control. You are welcome to ask questions as we go along. Questions at the end as well. This is going to last probably about an hour with questions, and then we'll do our 10 top tips at the end, which is just a little bit of snippets of advice for people, average dog owners with average expectations. All right, so crack on. Here we go. Shall I move on from your first slide?
Okay, yep. So I wanted to really talk about imaging and arthritis management because imaging is actually really quite important, I think, in the whole aspect of diagnosis, treatment, etc. So the next slide is just a lovely picture. So I sometimes put paintings in my slides because I think they cheer things up. We do things, we're very black and white in imaging, so it's nice to get a little bit of colour. And this is a lovely Arthur Wardle painting of terriers, and I think he has just captured them beautifully, such beautiful expressions on their faces that they sometimes cheer me up in the middle of a lecture.
It's a good thing, actually. It just keeps people attentive, doesn't it?
Yeah, and it's just nice to see. So what I really wanted to do was to look next at the types of imaging modalities. So these are words that you've probably come across. People tend to hear about, hang on, I'm just going to come down into my own one screen on here. So imaging, there are various types of imaging, and the general term that people use for that is modality. So you'll come across lots of terms that sound a bit confusing, but that just basically means types of imaging. So the main ones that will be used particularly for arthritis imaging will be X-rays, which you'll come across in most practices, CT or computed tomography, MRI, and ultrasound. Now, people get very confused by these terms, and they're very confused by which one's best in which situation. And actually, often there isn't a right or wrong way of that. X-rays are used mainly because they'll show bone, they'll show lung, they'll show soft tissue. They're widely available. They're fairly easy to take, and they're in most practices, so they would be often the first line of defense for imaging a patient that's got arthritis. What you will tend to find is how they work is that the X-rays, as they pass through the body, they make the screen or the cassette, the image will look black. So the more that come through, it'll be blacker. The fewer that come through, it'll be white. So bone is white, lung is black. And that's what you'll tend to see when you see your dog's X-rays on the screen. You'll see that the bone looks really quite white. The difficulty with X-rays is that it's just a single vertical beam, so it gives you pretty much a two-dimensional image. So when we X-ray a patient, we always X-ray them in 2 planes. So you'll X-ray a dog on its back and on its side, for example. If you were doing chest, or if you're doing the leg, you'll do them with the leg facing forward and the leg on the side. CT is a slightly newer kid on the block in terms of imaging and how we use it. It's still X-ray. I think that's the first important point to note. But what it does is they're X-rays that are taken 360 degrees around the patient as the patient moves through the donut. You've probably all seen CT units on the donut in a CT unit. And what that means is that nothing is superimposed in anything else. So it means that, for example, when you're doing bones, if you're doing a wrist or a carpus, or if you're doing an elbow, none of those bones are superimposed like they would be on an X-ray. So it gives us a huge advantage to start with. It also, because it's controlled by the computer, it means that we can optimize images according to what we want to see. So we might use a slightly different setting for bone, for example, than we might do for soft tissue. And I'll show you all of this as we go through. So you don't need to take it all in one. I'm probably giving you lots of information. MRI is slightly different. So MRI doesn't use X-rays. MRI uses radio waves. It's used a lot, particularly for soft tissue or for brain. So it's used a lot in neurological work, but it's used a lot in joints like the knee joint in humans and probably more in animals now because it allows things like the cruciate ligaments to be seen. So X-ray will show you where you've got arthritis change, but may not show you if the cruciate ligaments are intact. And the cruciate ligaments are the ligaments that you often hear referred to in football or knee injury. So Paul Gascoigne, I think, was the one who had a famous cruciate injury on his knee, I seem to remember.
Oh, amazing.
Ultrasound is used much less for joints. It can be used, this is again sometimes used in the knee joint because you can get right in and check the cruciate ligaments and you can check for fluid, etc. But it wouldn't be the first line that you would run to for assessment of a joint or to look for arthritic change. So I think if we look next, the important thing next is why do we bother with imaging? Well, I think some cases are really straightforward, and there are some cases that come through the door and you look at them and you think, actually, you know, that's very clear, that's most likely to be arthritis. And at the end of the day, common things are common. But I think anytime you treat a patient where don't have any evidence for what it is, you're making an assumption that your treatment plan is correct and that you are actually treating what's there. Now, there are some cases, I think, where it's really important to confirm that that is the case, particularly if they're out of the ordinary or if somehow they change. So if you've got a dog that's had arthritic signs for a long time and suddenly it becomes much worse, that may then be a time to think, okay, maybe we ought to have a look and see what else is going on here.
That's happened a few times this week on Holly's Army. So Holly's Army is our community group. Anybody that's watching this that hasn't heard of it, it's different to the page that you're on now. It's a group where owners can post their stories, they can ask questions, and it's overseen by vets and professionals, as well as the amazing ambassadors who are owners like you that's had further training. So they have private tuition so that they can monitor the page and make sure all of your needs are met, and we stick to evidence-based. So they will say whether something that you're asking, it has any evidence of effect behind it. So they're amazing people. But yes, this week there's been a couple of people that have had lameness that's not been improving. They've gone back, they've had a reassessment, they've had further imaging done, and they found that it is a different pathology at this point. So I think people sometimes are a little bit hesitant about going through the procedure again for fear of the sedation, for fear of the finance, for fear of whatever reason. But sometimes you really do have to. And hopefully, you'll have confidence to do so.
Yeah, I think it is important actually. And what I've got some cases, so I wanted to try to keep everything very pictorial because I think imaging that's what it is. It's all based in images. So I've got some cases to show that are real life cases that show that change as we go through. The other thing I think it's really important is a lot of the arthritis that we see in dogs is secondary to something else. So often it's important, particularly in the younger patients, to work out that we haven't got any additional disease. So for example, is there an underlying OCD? Is there elbow dysplasia? Is there hip dysplasia? Or in dogs like spaniels, is there any evidence that they've got a concurrent crack in the humerus? And again, I'll show you some pictures of that. So what those of you who have spaniels might have heard of intercondylar fissures, or IOHC as it used to be called. And so it's really important that some of those things are ruled out because it can make a big difference to the treatment options or to what happens next.
Yeah, and I think just to add a little bit, I think in my experience, people are always quite surprised at how significant the changes are when and I find it really useful for then getting the owner to be on board with my treatment plan. So we might suspect that there's some hip pain, and we do those x-rays, and when the owner looks at what their dog is living with compared to normal, you can see them go, right, and huge respect for dogs. What they cope with is incredible, but it's quite often a surprise at how extensive the change is.
Yeah, no, I think you're absolutely right. And I think what we'll do is that the next slide really tells us a little bit of what we can tell from an X-ray. And I don't really want to bombard everybody with lots of words, but there are some things that when you have the X-rays taken at your vet, there'll be some terms that they'll use. And I think it's nice as an owner to be able to understand what those terms are. And I think there's a certain way that joints tend to respond when they're inflamed, or when they've got arthritis there, whatever the underlying cause of that is. So there are some things we always look for on an X-ray to say that this is evidence that we've got signs of arthritis here. So the first thing is that you will often get new bone, little deposits of new bone that develop around the edge of the joint. And the technical term for these are osteophytes. And I'll show you these on the next slide. The other thing that we often get is erosion of the bone, and particularly the bone that's directly under the cartilage. So at the joint surface where you've got the two bones as they rub against each other, what they've got covering the bone is a little layer of cartilage, which is a slippery surface. With inflammation, that cartilage is often destroyed or eroded, and the erosion will then sometimes go right up into the bone. And we look for any evidence of that. And this is, it's very interesting. This happens exactly in people as well. The other thing we might look for on the X-ray is any evidence that we've got any loose fragments of bone. And the term for these is joint mice. You might have come across that term if any of you have had dogs, for example, that have had elbow dysplasia or OCD type lesions. The other thing you may or may not see, depending on the joint, which joint we're looking at, is some fluid in the joint. So radiographically, that may or may not be visible. Some joints you really won't see it on an X-ray. So, for example, in the hip joint, you wouldn't really see fluid in that. The stifle joint or the knee joint, you will certainly see it in quite clearly. It would have to be quite a lot for you to be able to see it in joints like the elbow joint. Now, the next slide shows two sets of X-rays. So the X-ray that we've got on the left-hand side is a normal elbow. So you can see, I don't think, Hannah, I can't, you can see the normal bone. So you've got the humerus that Hannah will point out. And then you'll see that that comes and joins with the ulna, which is the taller bone. And then next to that, just in front of it or alongside it, is the radius. And you can see the joint is the little dark surface between the radius and the humerus, if Hannah can point that out. Yep. And you can see this quite nicely. What you'll see on the normal X-ray is that you've got nice smooth bone margins. Now, if you look at the X-ray on the right-hand side, you'll see that actually we've got quite irregular margins around the bone. You've lost the clear definition of that lovely joint surface. And if you look just in front of the humeral condyles and slightly proximally, exactly just around about there, you'll see two little joint mice. You'll see two little extra areas of bone just up in here. So this already tells you that this patient's got a fairly advanced osteoarthritis with some evidence of joint mice. And if we look what this patient is like, you'll likely feel that this dog will have a thickened elbow. It's highly likely that you'll feel this and there'll be some abnormality on how this is palpable. What this will not allow you to do is to say whether or not this dog is lame. So the X-rays will never allow you to assess the extent of lameness in a patient. And this is what's important to remember, is that imaging is very clinical and osteoarthritis is a clinical diagnosis. So you're always using what you see on the X-rays with what you've got clinically going on with the patient as well.
Yeah, I think I'm always surprised at how different dogs have different degrees of arthritis and express it differently, and that you'll have maybe a Springer Spaniel with elbows like this and they're still like, I'm in the ditch, I'm in the duck pond, I'm in the forest, and they're just incredible. Whereas you might have, I don't know, more of a hound breed that's a bit more, nope, I'm sore.
Exactly. And the issue comes actually often if you've got bilateral, if you've got both front legs affected, then sometimes it can be really difficult to see a subtle lameness because it just looks like a slightly abnormal gait, and that can be much more difficult to pick up. And if we look at the next slide shows you the other view of the same elbow. So slide we had before was the elbow on its side. This is the elbow. The dog's resting on the tip of the elbow. And again, you can see the normal radiograph on the left. You can see the nice clear joint spaces. They're nice and clean, clear. And you can see the edges of the bone is nice and smooth. And yet, if you look at the image on the right-hand side, you'll see the irregularity on this kind of almost lobulated new bone. It's almost like it's got little clumps of bone that have just been deposited all along the side of the bone. So again, quite advanced changes on this side. So what can't we tell? Actually, the other thing we can tell, these are actually CT scans, and I'll go through a little bit further about CT in a minute, but the CT sometimes helps you to identify things like joint mice more clearly. So the image on the left-hand side is an elbow. You can see it's got really quite advanced disease. It's in fact the same dog from the x-rays. And you can see the advanced irregular bone that's on top of the olecranon and of the ulna. Hannah, can you point that out? Yeah, so this is often where Hannah's little cursor is often where the new bone first deposits, and that's actually an important area to look for very subtle signs of arthritis. But if you look just in front where I've circled with a little black circle and a black arrow, those are actually free fragments of bone in the joint. So this dog has had elbow dysplasia. He's got a fragmented coronoid process. You might have heard of that, of those of you who know a bit about elbow dysplasia, but it's where a part of the bone on the inside of the elbow fragments off, and those dogs will often get secondary arthritic change. The image on the right-hand side is actually a dog who has had significant OCD. So osteochondritis dissecans, which is a condition that is very common in large breed dogs. We often see it in Labradors and giant breeds. And it's a condition where the cartilage doesn't change into bone in quite the way it should. The cartilage becomes thickened and then it tends to fragment off. So it looks like some degree of erosion in the bone here. So these are the things that we can see on imaging, and which will, now that's quite a nasty erosion there. That
a pretty
looks
big
painful.
one.
I know, it looks really, really painful.
And it looks like a really nasty blister, doesn't it?
It does, exactly is what it looks like. And I think, you sometimes get pulled up short when you see some of these images, and it makes you relate to that patient in a completely different way.
Yeah.
So I have cried on occasions when I've looked at severe arthritis in some dogs' elbows, because you think it must be so sore.
And that, just so that people understand, that's a lesion already reasonably progressed. So this dog has been potentially lame for quite a while.
Yeah. And this is not an old dog. This is still a young dog. That's the bit that I find very difficult, and I think for owners is really difficult to take on board that, they have this lovely youngster, and suddenly, they find out that there's change there and significant change, and I think that's really hard, actually. I find it hard.
Well, Duncan Lascelles was on, I told you a few weeks ago, and he really has got quite a strong mission to try and get people to stop linking arthritis just with the elderly. He was, a very, very brilliant speaker, and talking about their work with a new tool called Coast, and how they're trying to get people to be aware of those breeds that are predisposed and be attentive to early signs. So that odd limp that keeps kind of being there, a slight behavioural change, slightly difficult to train. Why? Have a look into it, because we really, we do identify a bit too late in many situations, don't we?
I think so. And actually, I think one of the interesting things, and I always ask owners when they come in, one of the questions I always ask them is, do they stand up to eat or do they lie down to eat? Because the dogs that are really painful in their front legs, particularly if they've got two sides, often will lie down to eat, or they'll describe them. A young dog will come in and it'll be described as being lazy. And actually, often it's not lazy, it's actually because it's sore, but incredibly difficult to pick it up, because it's both front legs are affected, and therefore you don't really see a lameness. All you see is a dog that might actually want to lie down a bit more than you might expect for its age.
Yeah.
So there can be really quite subtle signs.
Just to big up another lecture that was given last Friday by Sam Lindley, she says very clearly in that often these dogs are just very well behaved, and people
Yeah.
the
Yeah.
control gets, we get it right. The dog goes back to being a little bit mischievous, a little bit pushing the boundaries, and that's quite sad, isn't it? To think,
Yeah.
oh, what a
And
wonderful.
I think that's not unusual either. I'd say we see that as well. You know,
Mm.
particularly the youngsters that come in if they've got really bad elbows. And there are some breeds, as you say, you know, where it will be much more likely. Now, what can't we tell from an X-ray? Well, we can't really look at the ligaments. So, for example, for a dog that maybe had a problem with the knee and was decided that that might be a cruciate rupture, you will not see the cruciate on imaging unless you do an MRI scan. So you won't be able to tell that from an X-ray, and a CT certainly won't help. So we often get cases that are potentially going to be referred for CT scans for cruciates, and we'll always say no because it's not the right imaging for them. We can't see the cartilage. The X-ray passes straight through the cartilage, so we can't see the cartilage itself. But what we can see often is the secondary change in the bone adjacent to the cartilage. In the knee or the stifle joint, there are little menisci, almost like little shock absorbers. Again, we can't see those unless it's an MRI scan, which is often why people use MR. And as I said before, it's only going to be some joints where you might see the fluid in the joint on the X-ray.
Just to butt in, because I only learned this in the last couple of years. I didn't realise that humans, they do the X-rays of, like, say, the knee standing, don't they? So that you can actually joint space.
That's right. Yep.
Pressure, cartilage depth.
Yep.
We don't have that privilege because we have to lay our animals because they're sedated or anaesthetized. So I did have somebody say, you know, can we assess the cartilage depth by the X-rays? And unfortunately, we can't because it's not a standing X-ray.
No, we can't. And it's interesting when you read the human papers, that is one of the big points that comes up is joint width is one of the things that they consistently go back to. And interestingly, even the very recent papers in People, they still have X-ray as number one of what they use. And I think it is one of the big differences. We can't really assess that. There are some cases where you can clearly see, particularly if there's significant narrowing on an elbow, for example, you might be able to see that the inside of the elbow joint is narrowed compared to the outside. So in dogs that have really severe elbow dysplasia, you might still be able to see that on a CT scan.
Okay.
But we can't do it in the same way. No, you're absolutely right. Okay. What I thought I would do is to just, because it's such a wide area, I thought I would just focus on some of the areas where we get arthritis perhaps most commonly. So elbows, hips, knees, and shoulders.
Okay.
And I wanted really to start with looking at the elbow, looking at what it entails. What is having an X-ray taken? What's it going to involve? Why does it take a while? Well, because there are three bones, and we've already seen a radiograph of an elbow, because there are three bones in the elbow joint, each of those will superimpose on the other. So it's important that you have three views at least. And often, if you're doing it correctly, or if you're being quite pedantic about it, you would certainly do 5 views. So you'll do a lateral view with the dog lying on its side and the elbow just in a normal position. And then you'll actually flex that elbow right up to try to see very subtle signs of new bone. And I'm going to illustrate this in the next slide, so don't worry. Then you might do an oblique view where you're trying to just highlight one particular side of the joint. And then you might do a craniocaudal view. So you're going to be taking 2 or 3 cassettes per elbow. And even in a very slick, well-run X-ray room, it's going to take you somewhere between half an hour to an hour, depending on just how slick you are. Because particularly with a large breed dog, it might take even longer because you've got to manipulate them that little bit more, and it takes a little bit longer to get them into position.
And it can have a nurse in tears very, very quickly.
Very quickly.
Position.
Very quickly.
So much patience, because quite often you'll be just slightly out and the image won't be good enough and you have to retake again.
Yep. That's exactly right. And you're doing that on both front legs. So it's not just that you're doing it on one side, you're going to do it on the other side as well.
On a 50-kilo dog.
Yes, exactly. So it can be quite difficult. Quite difficult. Now, why do we do that? And so again, I've just put up another slide that shows the anatomy, and it shows what we can see from the X-ray. Now, the next slide actually shows you the difference between, if Hannah can move to the next slide, it'll show you the difference between the lateral view on. That's it. And then this is the slide on the right-hand side is the flexed lateral view. And what Hannah will hopefully show us is that on the lateral view, you can see that the end of the humerus comes down over the part of the bone called the anconeal process. You don't have to remember any of these technical terms.
Oh, you do. Remember. We're testing you.
And what you'll see on the one on the right is that now you can see that anconeal process much more clearly, and that's often where you start to see just very subtle mounds of new bone developing. And actually the next slide, Hannah, shows that. So the next slide shows a normal flex lateral on the left, and you can see just a tiny little bit of new bone on the one on the right. Can you see just that tiny little bit of new bone there? So it's a really subtle sign, but it is there. Now, what this also shows you is that it's really important that the X-ray technique is good. So it is important that the patients are still, it's important that they're compliant. So, you know, they generally will be sedated or anesthetized, and either is fine. I think sometimes people worry about an anesthetic versus a sedative, but sometimes a light anesthetic is actually no more difficult for the patient than a heavier sedative. So I think it's often very patient dependent and surgery dependent, and it's important that your practice do whatever they are comfortable with, and everybody has a slightly different way of working, and one's not right and one's not wrong.
No,
there'll be different ways.
Just because I think I learned very late in my career, just in case any young new vets are watching this, can you just talk about the sclerosis as well? Because I kind of look back and I just think, God, I've probably missed quite a few. And it's another really subtle thing. So this is more aimed at any vets that might just happen to be watching. It's my my gift of my mistake. Really that aware.
Everybody makes mistakes. I think that's the first thing you remember, and the longer you do it, the more you recognize that, and I think that's really important. So I think the sclerosis is, if Hannah can point, because I can't point, but if Hannah can point, so the sclerosis for any vets is this, what we call the semilunar notch. And that, my understanding of that, when I was younger, we were taught that, you know, you looked at sclerosis and you thought that that was likely an indicator that there was some evidence of change on this elbow. But actually, I think the more that we've done now, it's recognized that that can be there, and actually is a very non-specific finding. So I tend not to use the sclerosis particularly as a way of identifying that. Now, one of the questions, I can see some of the comments on the side, and one is that dogs must get quite sore with manipulation involved. I think that's true, and even after CT, I always warn owners when they come in and they have their dog's elbow CT'd. Our CT bed goes right down to the floor, so the dogs tend to get onto the bed themselves. We don't lift them on and off. X-ray tables tend not to go down in the same way, but the CT bed does, for example, go right down to the floor. Because we're putting that patient in a position that they may otherwise guard themselves against, those dogs are likely to come back slightly lamer than they came in, and that might last for a couple of days. So yes, the anaesthetic and the sedation is quite important from that point of view as well, and also carrying on with any pain relief after the X-ray process and not being too worried. It's important obviously to mention it to your vet if your dog is significantly lamer post X-ray, but a lot of them will be for exactly that reason.
And they might not just be joint related, it might be muscular, it might be the fact, you know, they've been laying in a bit like us when we kind of sleep with our neck slightly twisted. Yeah. Yeah. And we quite often will send them home with additional pain relief just for a few days to see them through. We also are quite careful with what we choose for our anaesthetic. So we've drifted away from using the torbigesic in our sedative, and we're much more into our methadone. That sounds amazing, doesn't it? But, yeah, I think generally most practices are much more aware at how uncomfortable this procedure can be.
Yeah, I think so. I think for CT we still use Torbugesic, but then it's a much quicker process, and I'll go through that a little bit as we go on. You know, it's much, they're likely to be on the bed for 10 minutes as opposed to an hour.
Yeah.
And that's having done both sides. So it is a very kind of different process. So we tend still to use Torbugesic. And again, it lasts, I think, a bit longer than methadone probably lasts as well.
Yeah.
Yeah. If we go to the next slide, then this shows the next two types of X-ray. So this is the craniocaudal view, which we've seen one of those already, but you can see this kind of joint beautifully. So you can see the joint between the humerus and the radius, if Hannah can point that out, and then the joint between the humerus and the ulna. But now if we look at, this is the image on the left-hand side. It's fine. The image on the left-hand side is a right elbow. The image on the right-hand side is actually a left elbow, just to complicate things completely. And this is an oblique view. And this time you can see that it highlights really nicely the inner aspect of the joint. So if you had a dog that you suspected might have an OCD lesion, then this is a really nice view for highlighting that medial humeral condyle, which is that kind of inner bit of the distal part, or the lower part of the humerus as it comes in there. So these views are really helpful, and done properly, you'll get an awful lot out of a really good X-ray examination. So what else have we got in our armory? Well, CT, obviously. So CT is computed tomography. As I said, it's still an X-ray process. The tube head moves round, the patient moves through. We've got the lack of superimposition. And then if we go to the next slide, Hannah, again, for these patients, usually we'll use IV sedation for them. I actually find it slightly more difficult to scan them anaesthetised, just because of the fact you've got a tube and you're bringing in the head. We tend to scan them with one leg out and the head pulled right round to the side. That's a little bit more difficult with a patient that's anaesthetised, but not impossible. CT allows for what's called cross-sectional imaging. So you're looking at a slice in what we call the transverse plane, and in people they call it the axial plane. Again, you don't need to get particularly hung up on that, but it's a little bit like if you have a loaf of bread and you slice it into slices, you're looking at the cut surface of the slice. It takes somewhere between 5 and 10 minutes. But what we can do afterwards is we can then, so we just have to do one run through, and then afterwards we can use the computer to get the images in the other planes. So the dorsal plane, the sagittal plane, and then it allows us also to do these 3D reconstructions, which look beautiful and are often very helpful, but often all the image you need is on those initial transverse, dorsal and sagittal images. So this is how we position the patient. So these are what are called the scout scan. So that really is where we do put the dog in position. We do this little scan through, a bit like a low energy X-ray, and then we use that to decide which area we're going to scan through this. So this is a patient positioned for elbows. The next slide will actually show you what these images look like. The big benefit we have, as I said before, is when you X-ray a patient, the X-ray factors that you choose will determine how clearly you see the bone or the soft tissue. So if you use a very high exposure, you might find the soft tissue isn't very clear, and vice versa. CT gets around that because it allows you to apply different mathematical equations or formula, whatever you want to put it, to the raw data that you acquire, and allows you to look at specific images that highlight the bone beautifully or highlight the soft tissue beautifully. So this is a patient that has got arthritic chain. So you've got the bone on the left-hand side, and you can see the very clear detail of the structure of the bone. You can see the outer rim, the cortex, which is white, and then you can see the inner bit of the bone, the medulla, with what we call trabecular pattern. So this kind of slightly, how would you describe that?
Swiss cheese.
Okay, so it's got that kind of wispy appearance, and that's normal, and that's something that we tend to look at and assess. And if you look at the right-hand image, you'll see that the soft tissue window shows that this dog actually has a joint effusion. So can you see that there's a slightly darker area? Hannah, can you point that out exactly? So you see the slightly darker rim. Yeah. Hannah's got it exactly there. That's joint effusion in this particular patient. So it's a slightly different color to the soft tissue around it because it is fluid and not soft tissue. So you can sometimes see this. So you'll get a fair amount of information from these patients. So if we go on now and look at some patients.
Mhm.
So this is the first patient that we've seen. So this is a dog that is an older Labrador, had a variable lameness for quite some time. So varying between, I don't know if everybody will be aware of how we score lameness. So there's a score, almost like a scoring scheme. So you'll describe a patient as being 10/10ths lame if they aren't taking weight on the leg at all. If there's just a really subtle sign of lameness, you might describe them as being 1 or 2/10ths lame. So it'll be somewhere out of 10 to give you an idea of how lame the dog is. And this particular patient, when the owners were asked, thought it was somewhere between, ranging from 1/10ths lame to maybe 5/10ths lame on the right leg. Recently, though, this dog had become much worse. It was a sudden deterioration and there was some associated depression. He wasn't very well, not very happy, appetite had reduced slightly. So you see we've got 2 x-rays of the elbow here. We've got a right lateral x-ray and we've got a craniocaudal view. And the changes that are there are really fairly subtle, I think it's fair to say. There's not a vast amount of change. So you can see on the front of the head of the radius, Hannah, you can see that there's a few little fragments of bone just in there. And if you look where the anconeal process is, where it's superimposed on the humerus, there's a little bit of irregularity there. It's just not quite as clean and clear as you might expect. And if you look on the craniocaudal projection, on the inside of the elbow, on the medial epicondyle, if Hannah can point that out there exactly, you'll see that there's again a little bit of new bone there, but the changes are not particularly marked. But if we look at the CT findings, which are on the next slide, so now you can see the slide on the left-hand side is the transverse image where the radius and ulna meet. And this is a part of the bone called the radial incisor. You can see that it's really quite irregular. If Hannah can show that just between the two, that's it. Just down slightly, back slightly, just here, exactly, just along there. That's the radial incisor. Further up towards the tip of the coronoid, that's it. That should be much smoother than it actually is. It's really quite irregular. And you see the tip of the coronoid process here. Can you see how irregular that is? You shouldn't really have anything that's that irregular in a dog's elbow. It should be much kind of smoother and rounder. So this is new bone on the tip of the coronoid process. And if you look at the head of the radius, Hannah, just at the top of the screen, you can see the little double rim of new bone there. So that's very early, subtle new bone around the edge of the head of the radius there, that little double rimmed effect. So that's an early indicator of osteoarthritis. And again, if you look on the image on the right-hand side, you'll see that again on the edge of the humerus, on the other side, Hannah, yeah, on the other side.
This side, right here?
Yep, exactly. That's the medial side. You'll see again, you've got that double rim. This is arthritic change here as well. So those are what we look at on a CT scan to say that this is new bone, which shouldn't normally be there. Now, if we look at the next slide, I've got a comparison of the dog's lateral x-ray, which you can see on the left, and this is the reconstruction to look the same on the right. And now you can see much more clearly that new bone, that quite irregular new bone on the anconeal process of the ulna. Now, the thing that's interesting about the new bone here is that it's really quite irregular. It looks angry, doesn't it? It's got that really quite spiky appearance. If you look at the next slide, you'll see on the left-hand side, this is the soft tissue window. You can see the excess fluid in the joint. Can you see that, Hannah, the dark area? That's it there. Yep. So that's the joint effusion. That's excess fluid in the joint here. Now, because this dog was so unwell, we were concerned that there may be a septic arthritis here. And so what we actually did was he actually got an injection of a contrast agent, which is effectively, if people have had CT scans, it's often referred to as dye. It's basically an iodine contrast agent that's given. It's taken up in areas of high blood supply. It shows up white on a CT scan, and it helps to highlight the joint capsule. So if you see on the right hand side, Hannah, if you look on the, you can see if you go to the inside of that picture. Yeah, and down a little bit, can you see that the joint capsule is white? It's actually been highlighted. So just slightly further up, just on the medial condyle, exactly. Now, if you go slightly to the left, Hannah.
Yeah.
So you see the joint capsule is exactly where your arrow is, and that joint capsule has taken up some contrast. So there's inflammation in the joint capsule here. So this dog has got some evidence of sepsis in the joint, which is not uncommon in dogs that have had arthritis for a long time. It's not uncommon that then they will get some degree of infection, so sepsis or infection in the joint. So that will be very painful. Those dogs will be quite unwell, and the treatment will be different to just standard arthritis treatment. So it needs to be identified. It can be a little bit difficult to pick up. So sometimes you can take a sample from the joint and try to see what bacteria are there, or if you can identify bacteria. You might actually have to have a biopsy taken of the capsule, of the joint capsule, in order to identify it. So this is this is an example where it's not just a straightforward change that's there, and it's important to look further. Now, the next patient is a patient it's a young spaniel. So this was a 3-year-old spaniel that had been lame for about 6 months. Again, variable lameness. It went up to about 7 or 8 tenths lame, but might be as low as 2 tenths lame. So it had some x-rays taken, which if you look at the x-rays at first glance, don't really show an awful lot. So you've got the craniocaudal view on the left-hand side of the screen, and you've got a nice clear joint, not an awful lot of arthritic change evident there. And you've got the lateral projection again, not an awful lot of arthritic change evident there. But one thing we're always worried about in spaniels is it possible that there could be a little crack there? And if you look right in the middle of the craniocaudal view, just between where the radius and ulna exactly, where Hannah's cursor is, there's just a very faint, suspicious line there. Now, is it or isn't it? Very difficult to make a call on that. So this particular patient came in to have a CT scan. And on the CT scan, on the image on the left-hand side, you can see these 2 little kind of devil horns that are coming up from the anconeal process. Can you see them, Hannah? Just there, exactly. So that's very subtle early arthritic change. That's new bone development on the anconeal process. But if you come across to the slide on the right-hand side, you'll see that very clear crack right down through the bottom, or the distal humerus, or the bottom of the humerus there. And if you look on either side of that, Hannah mentioned, for anybody listening, Hannah mentioned sclerosis earlier. And if you look on either side of that, can you see the kind of broad white line on either side of that? So that's what we radiologically call sclerosis, so whiteness in the bone. I think it's a slightly incorrect, it's a radiological term. We're using the term radiologically, not, I think, in the way the pathologists perhaps use the term. Now, why does it matter that we would find out if that spaniel has got more than just a typical osteoarthritis? Well, if we look at the next slide, you'll see why. So we've got a standard radiograph here. And you'll see on the next slide, this was actually a patient, you'll see that this is fractured. So what will happen with some of those spaniels is that I've got a Springer Spaniel, and they go at 100 miles an hour, and they're in and out of ditches, and they're circling, and they're jumping, and typically they'll jump awkwardly into a ditch, or they'll jump a tree awkwardly, or one of the other, mine typically clears the other dogs when she's out on a run. Anything in her path will get cleared, and they'll land awkwardly and will fracture them. So this was the image on the right-hand side was actually from a Sprocker, beautiful, beautiful Sprocker, who had actually fractured his elbow there.
And that needs surgery. So
that needs surgery, exactly. And it's a completely different treatment option to the treatment option if you knew that it was there, which would be involved putting a screw across before you get to the point of fracture. So it's a more difficult surgery. It's a whole different ball game once you get to that point.
You want to be catching that definitely early.
Exactly. You want to be catching that early on. You want to know that it's there. And the other thing to remember is that it's often bilateral. So if you identify it in one leg, it's really, really important that you identify the second leg as well. You know, you image the second leg so that you know the second leg, the other front leg, so that you know whether or not you have any issues there as well, and that really is important. Now, the other area I'm going to look at is the shoulder. Shoulder arthritis is actually, you know, we see a lot of shoulder arthritis. A lot of it seems to be, you know, I think we pick a lot of it up incidentally. I know that where in my particular practice, we scan a lot of patients. We do a lot of cancer patients as well, and you might be doing a whole body scan on a cancer patient or doing a chest on a cancer patient, and you'll find that there's changes on the shoulders, but the dog's got no evidence of lameness, has had no, you know, particular clinical history associated with that. So I think it's kind of difficult sometimes in these dogs to know that it's there. This particular dog that I'm showing you here was a young border collie, so an inveterate ball chaser, ball obsessed as lots of collies are, and had vague forelimb lameness for quite some time, but it had started to become much worse. And so it had some x-rays that were suspicious that there was some change around the area of the biceps tendon. So again, you know, there are a few tendons in the shoulder that are very important. The biceps tendon is a tendon that comes from a muscle that attaches to the elbow, and the muscle runs up the side of the humerus, and the tendon actually comes across the shoulder to insert on the shoulder blade. And it's important for being able to move the elbow and flex the elbow properly. But the tendon runs in a little gutter on the inside of the humerus, and the image on the right-hand side, if Hannah can point to it, shows these two, almost like a little cup of calcification. Yeah, Hannah shows that that's right. It comes out there, and the tendon is now, actually, that shouldn't be there. Those two little bony spurs shouldn't be there. So this poor tendon that would normally try to be slipping quite nicely across the surface of the bone is now trying to do that with this great chunk of, or almost like it's encased in something, which is going to make it not move so easily and is going to be painful.
Holly had this, and I can remember, like, I won't lie, I don't feel that I really understood these conditions till much later in my career. And Holly was a collie, and she had biceps tendinopathy, supraspinatus tendinopathy, and I can't imagine how painful it was. But she just got on with life. And I've had supraspinatus tendinopathy, and I tell you what, it's horrendous. It's like someone stabbing you in the shoulder.
Yeah, I think it's amazing what these dogs get on with. On that radiograph, if you look at that X-ray, that CT scan, this is a CT scan, it's a bone window CT scan, what you'll see is, as well as having the calcification on the humerus where the tendon should run, and these are actually, the technical term for these is actually enthesiophytes, not osteophytes. But if you actually look, there's a tiny speck of calcium in the soft tissue. That's actually in the biceps tendon itself. So as Hannah's just talked about calcifying tendinopathy, when the tendon is really inflamed, as part of the repair process, it will often lay down calcium or bone in the tendon itself. And so you can see that that's an instance of it here. But actually, if you look on the image on the left-hand side of the screen, if you look at the back of the humeral head, so the back of the humeral head is towards the right-hand side of the screen, you'll see that there's a clear erosion. So you follow the white bone around. So that's called the subchondral bone. That's the bone that's directly under the cartilage. So you can't see the cartilage, but you can see that lovely smooth white bone. And then as you come here, you'll see that there's a clear defect in the bone. This dog actually has an OCD lesion on the shoulder as well. So there's two factors in this dog. So I think if you're going to just address one issue here, it may not completely address the problem. So it's important, I think, that often we're aware of any additional lesions that may be there. Now, if we look at the next slide, this is the same dog. I should point out, actually, to anybody listening, in case they think I'm being indiscreet, I have changed the names of these patients. So don't worry, they're all anonymized, and I have changed the names to make sure that I'm respecting patient confidentiality at all times. So we take that quite seriously, actually.
Yeah.
You know, it is really important that we're careful about that. So these are now reconstructed images. So you can see, if you look on the image on the left, you can see these beautiful, these are osteophytes. You can see these beautiful little spurs of bone here on the humerus, as Hannah pointed out there beautifully. You can see the calcium in the soft tissue just to the left-hand side of that image. That's it there. And then you can also see, if Hannah comes across to the right-hand side of the screen, you can see that lovely spur of bone there on the edge of the scapula. Now, I'm saying lovely spur of bone, don't get me wrong on that. That I'm saying lovely purely from the point of view of it being a descriptive lesion. Not that I think it's lovely that this dog has this issue at all. So I'll just clarify that, because it's, you know, you and again, the next image, you can see the image on the left, right-hand side of the screen. Again, you can see those deposits of new bone there. So these are all the arthritic change around this poor dog's shoulder. So it's important. Now, the next patient, if we look at the next patient, this patient was she was a 7-year-old crossbreed, a very lively, active dog, and lots of the dogs that have trashed their shoulders along the line will have been incredibly active, very bouncy. And she wasn't. She'd had a history of stiffness for some time, which had suddenly become marked, and she developed quite a severe right forelimb lameness. But she had also become really quite unwell, and again, that's quite unusual. So, you know, dogs that have chronic arthritis, they'll have a lameness, they might get worse for a while, and it may get better again. But dogs that become clinically unwell is quite different. So she's had some x-rays taken, and you can see, if you look at these x-rays, these show the difficulty actually sometimes with x-ray on the shoulder, because you've got the neck in the way, and you're going to get superimposition of the neck and the trachea. So you can see the trachea here, which is very close to the shoulder joint, as Hannah will show you there. And you can see the end of the endotracheal tube. So she's an anaesthetized patient, and so this is the tube that's helping her to breathe, that's in the trachea here. And if you look superimposed on the trachea, just in front, you'll see that little calcified area, as Hannah's pointing it out there. And if you come onto the distal scapula, Hannah, just in front of the scapular spine, cranially, sorry, yeah, you'll see another little calcified area there, superimposed on the bone. So this dog has got signs of a tendinitis or tendinopathy, and as Hannah said, it's likely to be in a tendon called the supraspinatus tendon, which often will find calcification in, and these dogs don't seem to have any clinical issues at all, and it can be quite difficult to know what you do about it or don't. Now, if you look at her right shoulder, there's very similar changes. So you can see these little calcified areas, and you can see some on the back of the shoulder joint as well, which is possibly in the infraspinatus tendon, just a slightly higher up, Hannah, yeah, up there. But if you look actually, Hannah, just in the cranial aspect of the humerus, just directly under the ET tube, slightly further forward and slightly down a little bit. So you'll see here that the trabecular pattern of the bone is slightly patchy. So by the trabecular pattern, we mean this kind of wispy appearance that you see, that's the inside of the bone, that forms the structure of the inside of the bone. That's the architecture of the bone marrow, if you like. And you see, it's just really subtle that looks a little bit different. And if you look just at the front of the bone, just about level, that's it, you'll see there's a little bit of lifting of the periosteum there. So the periosteum is the surface of the bone. It's got the nerve supply, it's got the blood supply comes in through the periosteum. And that, you'll see, it's incredibly subtle, the change on this shoulder. So
I think it's brilliant because you've actually chosen not the classic, you know, in your face one. Yeah, it's good. I love this because it shows how complicated it can be.
It can be really complicated, and I think the subtle in your face ones, there's no doubt about those. It's these ones that are much more difficult, and I think are much more difficult to identify. Now, if you look here, you'll see, so we've got 2 CT scans on the next slide. So there are 2 CT scans, and I've done reconstructions to make them look like the previous X-ray. So these are what are called sagittal reconstructions. So as if we're looking at the bone down the middle, like with his arrow. Was it Sagittarius with his arrow that slices things in half? Yes. They're called sagittal reconstructions. So this is the sagittal plane, and you'll see that the left shoulder on the right-hand side of the screen, you'll see the very clear cortex, which is the outer hard rim of the bone. And you see that's very clear. It comes right up into the groove here, which is the where the intratubercular groove here. And you'll see that that's really very clear. Now, if you look on the image on the left, which is the dog's right shoulder, you'll see that's completely different. You'll see we've got some erosion here. It's destroyed. And you'll see this very subtle lifting of the periosteum right at the front. Yeah, there's a name for that. So that's often called a Codman's triangle, is the radiological term for that, which nobody needs to remember. But if anybody wanted the technical term to go with it,
I expect you to remember that.
that's what it's called. So this is very subtle, but because of these findings, if we look at the next slide, Hannah, we've got the dorsal plane reconstruction, and now if you look, you can see that periosteal reaction much more clearly just there. Dogs with arthritis get new bone that forms around the joint. They don't usually get a periosteal reaction. So the periosteal reaction is either tumour infiltrating the bone or inflammation of the periosteum of the bone. And that is something that sends up all sorts of concern signals if you find that appears. This dog actually subsequently, this was actually a metastasis from a lesion elsewhere.
Oh, wow.
So this was not a primary bone tumour, this is actually a metastatic bone tumour. So this dog had lots of additional lesions. So she had some lymph nodes in her chest, she had some lymph nodes in her abdomen, and it turned out to be a tumour called, most likely, again, pathology wasn't completely certain, but it was most likely to be a tumour called histiocytic sarcoma, which can appear in different regions. So not very nice at all. So again,
what breed was she?
She was a crossbreed.
She was okay.
Beautiful, beautiful, beautiful dog. As is often the case. Often,
very true.
Very true. So again, the importance there of different types of imaging, and just not assuming that what I know common things are common, but sometimes you get a feeling that this is not a typical presentation, and then you've got to look further in those cases, I think, and you've got to think outside the box slightly for those cases. Now, the next patient, again, a beautiful, lively dog, no particular long-standing history, but over the period of probably 6 to 8 weeks had become really quite lame on his left forelimb. And so you'll see we have got CT scans of both shoulders, and you can see from some of the images you've already seen that there's evidence of arthritis and change in the biceps tendon, as Hannah's pointing out here on the left, and arthritis on the right-hand side. But actually, what was different with this dog was that this dog was now 10/10ths lame. So we'd already scanned the elbows, which looked fine. I think this was a Labrador. We'd already scanned the... No, that's fine. You can stay there. That's fine. I haven't put up the elbow images, but we'd already scanned the elbows in this dog because that, would have been the first area of concern. We've done the shoulders. The concern here was that there was quite a lot of muscle wastage. So by that, I mean that the muscle had wasted away on that side. So there was atrophy because he wasn't using that leg. But it seemed to be just a bit more than that. It was really quite marked over that period of 6 to 8 weeks. And again, that sends all sorts of alarm bells ringing. Well, that's really been very quick. Is there anything more there? And the thing that you would always be slightly concerned about then is there any possibility that actually we've got a nerve root tumour in this patient? And so we went to look further. So this is a CT scan through the front of the chest. So kind of at the bottom base of the neck, front of the chest. And when you CT these patients, you can see that we've got some contrast here because you can see that the blood vessels, if Hannah can point those out, are slightly brighter. Yeah. And what you're always doing is you're looking for symmetry between the right and left side. And I think the first thing that pops out is that we've got on the patient's left-hand side, which is on the right-hand side of the screen, that's how we tend to display things. You'll see where I've got a round marker there. You'll see that there's a mass type of round structure. It's not on the left. It's not on the right-hand side of the patient, which is the left-hand side of the screen. Sorry, that's a bit confusing, isn't it? I don't want to confuse everybody with that. When you put up images, you put them up with the patient's left on your right and their right on your left. So that's what we've done here. So you can see this clear lesion or round abnormal area mass, if you like, in that area. You can see it's taken up contrast. It's quite bright. on the surface, and this is very typical of what you get with a nerve root tumour. So this is actually arising in the nerves in the armpit, so the nerves that arise under the arms. The technical term again is the brachial plexus. You don't need to remember that, but that it's a mass in that area. Now what we can do is then to reconstruct that, and if we look at the next slide, you can see this reconstructed. So you've got the sagittal reconstruction, so as if you're looking through the side of the patient, and then as if you're looking on the left hand side, as if you're looking through the top of the patient. And this time what you can see, particularly in the image on the left hand side, you'll see, it's all right, you'll see where the black arrows run. You'll see that this is the nerve coming down into the leg. You see how thick it is. You really can't see them very clearly on CT scan at all, not like on an MRI scan. But as you follow that right back into the armpit here, you see it comes right into this mass. And again, if you look on the sagittal reconstruction, so looking through the dog's side, you see the mass here, where the slightly bigger arrow is, and then you can follow it as it comes all the way up into the spine. So these nerve roots originate in the spinal canal, and they come out through the little gaps called the vertebral foramina in the vertebral bodies, and they come down and into the brachial plexus and then down into the leg. So it's important that you can identify that they're there, and it's important that you can identify how far they spread, and that you can then work out, is treatment possible? Sometimes it is possible to take these out. It's not surgery for the faint-hearted. And you always want to know, of course, that there aren't mets elsewhere. This dog, I haven't shown them, but this dog had metastatic disease already. Right. So this is, again, a dog that might have...
Metastatic, so they know, means that...
Metastatic means that they've spread, exactly. And the typical place they might spread to would be the lungs or the lymph nodes or liver or wherever. In this particular dog, they had actually this had spread to the lungs, so there are already lots of little nodules through the lungs. So although this was a dog that might have the hallmark features in lots of ways, so there's lameness, it's an older Labrador, it's got forelimb lameness, and you might look at that and think, well, okay, maybe this is just elbow disease, but actually the fact that it was 10/10 lame doesn't go with that, and the fact that you had such marked wastage of the muscle doesn't tend to go with that as well. And again, that suggests that we need to look further.
Yeah, definitely.
So the next area, sorry, I hope I'm not droning on too long for everybody here. The next area I was going to look at really is the hips, because again, there's lots of, it's particularly older dogs, particularly shepherds, Labradors, whatever, will have hip disease. And it's important, I think, that people understand what is it that we look at when we look at hips. How do we scan them? How do we image them? And I think one of the things I would say is that X-ray, I think, still remains one of the best ways of imaging hips. So CTs are great, but actually it can be really difficult to get the whole view that you have on this X-ray, for example, where you're going from the lumbar spine, if Hannah can point that out, just in front of the pelvis, all the way down to just underneath the stifles. And you get this lovely clear run. Really difficult to do that on a CT scan with reconstruction, and I'll show why as we go through. So these patients, again, are usually sedated or anaesthetised. They're going to be positioned on their back. They will have the hind legs extended behind them, and they'll often have the stifles pulled inwards and then taped together to make sure that you keep those femurs or the thigh bones parallel as you have here. And what's really important when you have the hip or pelvis x-rayed is that your positioning is really accurate. So if you look at the pelvis, you can see that we look at the wings of the ilium, if Hannah can point those out. So they need to be really symmetrical. And if we look at the obturator foramina, which are these two holes here and here, they need to be symmetrical. The reason for that is it's really easy to artifactually make hip dysplasia look worse because you've positioned the patient badly. So when you send them off, or if they're being sent off to the hip dysplasia scoring scheme, they're really quite rigid about what they will and won't accept for exactly that reason. So this is a set of images. This is a lovely set of hips. The other thing you'll see looking at this is the other thing you can assess from this very nicely is the soft tissue. And if you look at the thigh muscles on each side, you can see that they're very symmetrical on each side. So no real change here.
And I've got trousers.
Yeah, they do. They do. Yeah, they do. They're like the trousers. My son brought some home from my daughter from Africa. They look like those kind of bell balloon trousers that people have.
Trousers.
So if we look at the next, so this is typically if you are looking for hip dysplasia, you will have that extended leg view that I've just shown. Sometimes if you've got a patient who's very sore, or if you've got a patient where you're worried there may be some fractures and you're worried about stability, you might do one of these frog leg views, which show the pelvis in a slightly different way, but you can see beautifully the pelvis outlined here, but you can see the ball and socket joint nicely. So the ball being the head of the femur here, and the socket being the acetabulum that it sits in. So those are, again, the technical terms for this hip joint. So that the technical term for that joint is the coxfemoral joint, but it is effectively a ball and socket joint. And when we look at it and when we're assessing it, we're looking at how well that ball sits in the socket. We're looking at the shape of the socket. We're looking at any evidence that there's a new bone around the socket, or that we've got a new socket joint, as I'll show you as we go further over. So if we go to the next slide, this actually is I've shown you one re-windowed, sorry. Yeah, sorry, I missed that one out. So when we take digital x-ray, so a lot of practices now have digital x-ray machines. And one of the advantages of digital x-rays is that you can actually change the windowing. So you can change the color, if you like, of the x-ray on the screen. So this is maybe how it's been taken, and this is how we then can subsequently re-window it. In order to do that, though, it's really important that these images are submitted as what we call DICOM images. So again, without getting very technical about it, each medical images have a special format of their own called DICOM. So it means that it's a universal format for medical images that will go across all particular types of imaging equipment. So whether it's X-ray machines, whether it's CT machines, whether it's ultrasound machines, MRI units, they will all produce the same type of image. And it's an image that's a stable image quality. So the quality of the image does not change no matter how many times you open it. If you open and close a JPEG image all the time, the image quality degrades. And in order for you to make a DICOM image into a JPEG image, some information is taken from that image. So you don't get the full thing. So you'll find that radiologists aren't being awkward if they say, look, I can't interpret a JPEG image, I need to have a DICOM image. The reason for that is that actually that's important professionally, that's what we do, so that we can do the best. But it also means that we can do this, we can re-window them. We can be more accurate in how we look at these images. And the re-windowing sometimes helps you identify parts of the joint slightly more clearly than you might have done before. So if we look at the...
Sorry, Hannah. Advanced we've come. Like I started when we had automatic processing.
Yep.
In 2002. And there was occasionally a practice I'd go to that was still dipping.
Okay.
Terrifying.
Well, when I started, Hannah, one of the first practices I worked in used a machine that used to be dropped to the army during the Second World War.
No way.
Bearing in mind now, I've been qualified for 30 years, so that will tell you something. We still used to do wet processing then.
Yeah.
So, things have changed massively.
And that's just huge labour of love, wasn't it? If you couldn't get the right position, just...
Absolutely. It was an entirely different process, I have to say. It's changed massively for the better, and certainly much better for the patients. It's
Definitely.
like as much, with the imaging modalities that are available these days, it certainly means that no patient should have to go for an exploratory surgery without the surgeon being aware of what they go into, or, it is much easier to get much clearer identification of what's going on with the patient than before. So if we look at the next patient, so this is a patient, I'll show you the close-up in a minute, but this is just the x-ray that you would first of all take. I'm sorry, it might be a little bit small on the screens, but the first view of that, it doesn't look particularly awful. But if you look a little bit more closely, and if Hannah will do the honours with her magic cursor, what you will see is that when you look at the ball of the femoral head, if you made it into a circle and you put a little dot in the middle of the circle, that dot in the middle of the circle sits just outside the socket. So, Hannah, can you show the little S shape behind the femoral head?
Yeah.
And that is that's the back of the socket joint.
So there. Yep.
Exactly. So that's called the dorsal acetabular edge, or effectively it means it's the top of the socket joint. And in order for a dog to have good hips or no evidence of hip dysplasia, that ball should sit right inside that socket joint, or more than 50% of the ball should be within the socket joint. If it's less than that, that's an early sign, or it's a sign of mild hip dysplasia, and would get scored accordingly. What we're also looking at is, if you look at the femoral neck, if Hannah can identify that femoral neck on this side is a little bit thickened compared to the other side. So there's likely to be some new bone here, which is again some signs of early arthritis, osteoarthritis around this joint. And if you look, Hannah, at the cranial acetabulum, so the front of the acetabulum, yeah, and look at that curve. That should be, you can see that that's quite flat. That should be much more of a semicircular curve as it comes round. So these are really subtle changes, but these are signs that this dog has got a subtle and early hip dysplasia. Maybe not an early hip dysplasia, but the hip dysplasia is there, but has got subtle signs and has got still very early signs of.
How old would you say this dog was?
I can't remember how old this dog was exactly. It's not an old dog, because you can still see the scars on the femoral head.
Mm-hmm.
So it's not a particularly old dog. I can't remember offhand. I've actually tried in some ways not to find out too much about some of the x-rays, because I don't want to make a slip and use the wrong, use the patient's real name. I'm trying to be really careful.
Yeah. I love your choice of names. There's Mal and
well, they're kind of, it's just a way of reminding me who they are. Now, if we look at the next slide, this is a patient who has got more marked hip dysplasia. So you can see it's on one side, on the right leg. You'll see that the appearance of the ball of the joint is completely different to the other side. So you'll see, whereas on the dog's left side, on the right of the image, you'll see that you've got really quite a nice clear ball, although it doesn't sit beautifully in the socket. It's not awful. But if you look on the right-hand side, you'll see that that's missing completely. You can't really see the neck. And if you look, Hannah, down at the bottom of the acetabulum, just slightly more, yeah, exactly, you can see that there's new bone in the actual socket itself. So that kind of slightly bobbly appearance that we have there is signs that there's arthritis already in that socket joint.
Mm-hmm.
So it's certainly an indication that this dog, now you probably can't see it from here, but this dog has got a smaller muscle on that side, because that just not using that leg in quite the same way as on the other side. If we look at the close-up, which is actually the next slide, I've done two windows here. So you've got the image as it was taken, and then I've re-windowed it slightly to show the changes slightly more clearly here. And you can probably see more clearly now if Hannah shows that new bone exactly in the acetabulum there, exactly. And you can see really the irregular change around that femoral neck. And how can you see the dorsal acetabular edge there, Hannah? Can you see the S shape at the back of the joint? Yeah, exactly. So you can see how little of that femoral head or ball actually sits within the joint.
Nasty.
It is nasty. It is nasty. Now, is this dog lame? Who knows? I've seen some patients that have come in lame with much milder changes, far milder changes than that, and I've seen others that appear to be relatively sound, with an abnormal gait, to be fair, but relatively sound and seem perfectly happy and have much more severe changes. So it is really important that you keep the two together. Now, if we look at the next patient, this is a much more severe case, and you'll see that although there's less new bone, there's almost complete luxation of this leg. So when I say luxation, it means that ball is not in a joint at all, and there really isn't a socket there any longer. It's almost made a new joint. This is what's called a false joint. So you'll see that it's almost made a new joint as we go further up here. And that's why positioning in this patient has been slightly more difficult. You know, with these dogs, it's really difficult because the legs just don't want to go into the right position. And equally, you know, it's going to be really painful to try to force that issue. Not obviously not physically force, but, you know, to try to reposition them, it'll be really very painful for them. So you're always looking at what you've got and kind of working out then how you image that patient. And that's the thing with imaging, it's a really clinical discipline. You're always looking at the patient in front of you, what you've got, what can you see in this, and how then change how you move forward with your imaging based on that. So I think it's one of the things actually I feel very strongly about, is that it very much is a clinical discipline. So these are scout scans of a CT unit of a pelvis on the next slide. And this actually shows why it's quite difficult. So when you CT, you are slicing all the way through this in virtually, obviously, 0.5 millimeter slices or millimeter slices all the way through these hind limbs. But because the hind limbs come up into the air, it makes it difficult on a CT scan to get a whole reconstruction as easily as you would do on the set of x-rays. So that's why I find that they're not as useful as x-rays for diagnosis of hip dysplasia, and not really required. What CT can show, so this is a patient that's got really marked muscle wastage. You can see the difference there really quite dramatically. This was actually a dog that had a problem in the knee joint, not actually in the hip joint, but you can see the marked change on that patient's left side where Hannah is now compared with the other side. So really quite severe change. And then just lastly, if we come towards the stifles or the knee joint, there's probably a lot of you will have patients that, or have had animals, that pets that have had problems with stifles or knee joints. It's a really kind of common sight of problem in dogs, and some breeds perhaps more than others. And again, as often, you know, if one leg's affected, often the second leg will go very commonly in some of these patients. So when we x-ray, here we've got a lateral and a craniocaudal or caudocranial view. So you can either have the dog on their front and coming through the back of the joint through to the front of the joint, or they'll lie on their back and the x-ray beam comes from the front of the joint through to the back of the joint. And the way we label them, whether it's craniocaudal or caudocranial, will be a determination of which way that x-ray beam has gone. So has it gone from front to back, as in craniocaudal, or back to front, caudocranial? So that's what those terms mean. They're nothing to get concerned about or worried about, but just means which way they've gone through the joint. Now, when we take these x-rays, or when we look at these sets of x-rays, this is a youngster. So you can tell that it's a youngster because you can still see the growth plates, if Hannah can point those out. So these growth plates will still have some cartilage in there so that they'll be dark. And if Hannah can point out the anatomy as we go through, so you can see the femur. We've got the shaft of the femur as it comes down, and you can see the cortex and the medulla nicely, and you come down into the what we call the femoral condyles, so the two little knobbles at the end, and you might see those more clearly on the image on the right, if Hannah can point to those. So those are the femoral condyles here. That's the term I use for these two knobbly bits. And that's, again, these are important because this is where you might, for example, see a stifle OCD lesion. And the cruciate ligaments sit between these, so they cross over between these condyles, and we can't identify them on an x-ray or on a CT scan. But what you can see on the x-ray is that if Hannah can come to where the kneecap is, so the patella or the kneecap is here, it sits in between these, and Hannah can maybe point it out on the opposite image as well.
Oh, sorry.
Oh,
got a ghost in the system. There you go.
Yeah, so it should sit right in the middle there. It's exactly where it sits, just at about that level. And then, Hannah, if we come across to the left-hand image, again, the lateral projection, so you can see the patellar ligament on the surface. And then just under that, you can see a slightly darker area. That's fat. So fat has a slightly different appearance on an x-ray compared with soft tissue. So fat will be darker because it's not such dense tissue. And if you go slightly behind the fat, Hannah, further into the joint, yep, you'll see that's the joint fluid in there, where Hannah's arrow is now. And then if you come to the back of the joint, Hannah, where we've got the popliteal sesamoid, yep, yeah, and that you'll see little dark lines that run down the back. Yeah, these are important because that's the back of the joint there. These are what are called fascial planes. So the joint shouldn't really extend beyond that area. And then you can see the two little, what we call fabellae, just up above. And these are two little bones that sit in the edge of the muscle. So when we get arthritis in the stifle joint, we get irregularity of those two little bones there as well. So when we look at a stifle x-ray or a knee x-ray, we want to see that we can see that fat pad. We want to see that we can see those lines that run down the back of the joint because there's no sign of any fluid in the joint then. We want to see that we can see the kneecap sitting where it should sit and that it's on midline on the other view. And we want to see that there are lovely smooth edges of the patella and of the edge of the tibia, which is the other bone here of the knee joint. Is that fairly clear?
Amazingly clear.
So if we go then to the next patient, so we've got a normal on the left-hand side. Now this isn't such a good X-ray. This was not a digital X-ray. So this was an X-ray that I've had for quite some time, and I've digitized it, so it doesn't look quite so nice. But what you can see here is that you've got the normal X-ray on the left, and if you look on the right, can you see the extent of fluid in the joint, Hannah? Yeah, so you can see how far out it comes, and you can see that it actually bulges all the way out at the back of the joint as well. So if we lost the fascial planes, and you've got quite a big bulge at the back of that joint. And if you look closely, you'll see some little spikes on the end of the fabellae there, and you'll see if you go at the end of the patella, yep, just there as well, and a little bit of new bone just above the patella. Oops. A little bit of new bone just above the patella there, yeah. So those are all the areas that you're going to look for signs that you've got some arthritis of the knee joint. So you can see those there. Now, what's caused the arthritis there? Very commonly, it will be cruciate disease, and I think the next patient maybe highlights that. So this is a dog. This is a dog that has a cruciate rupture on this leg. So again, you can see we've got the fluid in the joint. So a very small fat pad there, hardly any fat pad at all. And you can see quite an irregular plateau on the tibia. So that kind of, exactly, that flat surface of the tibia looks really quite irregular, quite spiky new bone. Spiky new bone at the back of the tibia. Yep, exactly down there. And then quite a lot around the fabellae. Yeah, and on the distal humerus as well. Distal humerus, we're doing well. Distal femur. Sorry, I often say the wrong thing. And then the next, this is the last kind of important one, is that this is the patient with OCD again. So you can see, you've got that erosion here that may be an underlying cause for some of this arthritic change. So just identifying that this patient has arthritis sometimes isn't just quite enough. It's
was it the same one? So did it have cruciate and OCD?
No, this is a different patient. Yeah, this is a different patient. So you can see we've got the sagittal reconstruction on the left, which Hannah's showing you with that horrible erosion. And then really what you see on the transverse plane, which is on the right-hand side of the screen, is you can see that clear, bright area that I've highlighted with red arrows. Really bright tissue, which suggests that there's some change in the bone there. It's clearly potentially bruised. Is that the right term? If you did an MRI scan, you might see some evidence of bruising. So MRI is lovely in these cases as well. Why do we not use MRI more? Well, I think for stifles, often people will use it. It takes longer. It's depending on whether it's slightly complicated. Depends which type of MRI system you have. But certainly, some of them will take quite a long time to do that. It may be really quite expensive. Often there's enough information in an X-ray scan. as I say, I wouldn't CT a lot of these stifles, because if you are looking for cruciate disease, I'm not going to get you the answer. I'll tell you pretty much what you can see on the x-rays, maybe in a little bit more detail, but we're not going to. And I think that's what we try to do is to be very clear about only doing the procedures that we think are going to be beneficial, obviously, for the patient, because anytime you sedate a patient, there's a risk involved with the sedation in any case. And obviously, you're only going to want to do that the minimum number of times that you absolutely have to.
I think that's
it's
a good
obviously very safe, but
someone again, Holly's Army, someone mentioned the other day that their dog had the MRI for lumbosacral disease confirmation, and the dog was really sore, and I had that with Holly as well, in that, because it was such a longer procedure.
Absolutely, yeah, it's a long procedure
for a lot longer, and it took her a good 10 days to recover from it. You really think, what have I done?
Yeah.
She did recover. Whoever took the message on there on Holly's Army, she did recover. But yeah, I know how you feel. It's you feel uncomfortable with your decision. The decision was for the best reasons, but you sit there thinking, did I do the right thing? But
yeah, I think that's right, and I think it is difficult. I think it's and I know that from being an owner as well. You want to do what is going to give you get you the maximum result with the least impact on the patient. Because it is very difficult for them. And I think we ask a lot of them, and I think it's interesting. It's important that they're seen, but I find it interesting, how tired a lot of those patients are the next day, even if you haven't, ones that come for ultrasound, I always warn people they're going to be tired the next day, even if we haven't sedated them, because it's been a big deal. They've come and they've had to behave, and they've been on their best behavior, and they'll be a little bit nervous. And who are these women that are, scanning my abdomen and shaving my hair off? And I think it is a big deal for them, so it's important.
And I think that applies to anything that we ask of them. So somebody brought up recently about grooming. Standing to be groomed when you've got less. I think a lot of people think standing is just like a passive act. It's not. It takes a lot of stamina and strength to hold that posture. So we just have to be really aware what we ask of them. Just think ahead, really. I strongly feel anyway.
Well, I think you're right, and I think particularly if it's a forelimb issue where they're going to take, we were always taught they take 2/3 of their body weight through their front legs. So particularly if you've got a heavier dog and they're taking a lot of that weight through their front legs, it is important to be aware of how you handle them and getting them to do as much as possible without you having to manhandle them into position. That all helps keep them more comfortable, I think.
Yeah, definitely. And something that we were trying to coin was considerate handling and considered handling. So when they are anaesthetized and sedated, all of their coping, their what am I trying to think? Compensatory mechanisms, their support structures are potentially gone, and therefore there's going to be movement that isn't appropriate for them. So we just have to be really careful about how we handle them once we sedated them.
Yeah, absolutely. So I think I think probably the most important point is that imaging won't give you all the answers. So it will certainly help. It'll help, as we said, confirm things. It'll help rule out additional disease. It may help decide the extent of severity, but it won't give all the answers. And I think we often amongst ourselves have huge debates about, well, which way should I image a particular patient? Should it be a CT scan? Should it be an MRI scan? Would it be better just to be standard X-ray? Should we use contrast? And I think sometimes there isn't a right or wrong way of doing that. And sometimes you'll have patients that will need to have X-ray, CT and MRI. Obviously, you try to minimise those cases, but sometimes that is how it ends up being. I think it's the same in the human field as well.
And I'll add to that, poor old Holly sounds like she was experimented on, but it wasn't. It was always with the best intention. I thought that she had neck pain, and so therefore we did X-rays and we didn't see anything conclusive, and it was just, oh, could there be something? So then she had a CT because I was working at New Priory in Brighton, so it was on site, and there was a little gasp of, oh, could that be something? Right. And then she went for an MRI and they didn't find anything. And unfortunately, about 2 years later, 2 years later, going back to the X-ray, there was spondylosis, lots of sclerotic change, collapsed disc space. Clinically, there was something there.
Yeah.
You both. You really do, don't you?
Yeah. I think you do. I think you do. And I think actually, you know, part of the imaging is going to be that part of the imaging really is to look at, are there any underlying conditions that might change the treatment plan? So I think sometimes it's difficult. You think, well, why am I going to do this? Why am I going to do all these extra images? Do I really, as you say, want to put them through this? But I think particularly if it's a change in how a patient presents, or particularly if a patient is presenting, although they might have the right age and they might be the right breed and it might be the right joint for you to assume that it's arthritis, if everything doesn't tie up, then I think it is important then to say, actually, you know, this doesn't quite seem right. I think we need to look further here. And I think that's what I was really kind of trying to highlight. Why we image, how we image, and when it is important.
I think you've done amazingly. And my brief for Paddy was really wanted to create content that we can refer new people back to. Let's get rid of this and pop you up here. I wanted to be able to have something that when we got new people to the site that are questioning whether to go through a review, for example, or whether to actually go through imaging for the very first time, what the importance behind it is. Because definitely in the older generation, I do feel that we quite often as an industry say, oh, well, it's going to be, let's not put him through, let's save your finances for, you know, treatment. But there are occasions where I really do think that we should encourage owners to, you know, be on board with getting detail.
I think absolutely. I think it actually often then it's often time effective as well. I think sometimes CT is absolutely not right in every case, and I don't think it is. Sometimes though you find that going that step further is time effective and cost effective in the long run for some patients, but not necessarily in all arthritic patients. You know, I think just as a general term, it may seem like it's a real step too far, but actually it often helps identify things faster.
Yeah, and I think most vets of my age have got stories of, I wish I'd done that a few months ago, and we would have more of an answer. And we've got some questions before we do 10 top tips. Let me just see if I can get them up.
I hope I can answer them.
Oh, I'm sure you can. Do dogs get Perth's disease like humans? Would that show as degradation and flattening of the head of the female on X-ray?
Yes, they do get Perth's disease. They do get Perth's disease, and it does show exactly like that. So you find that the femoral head tends to look slightly different. It often doesn't look as bright as it should do, and it will often look misshapen and flattened, as you say. So particularly, I think we often see it a lot in terrier type breeds.
Yeah.
Would be the dogs that we tend to see it in, but yes, you definitely do get it in dogs.
On the normal stifle X-rays, what is the gap on the tibial tuberosity? That was at the there was the radiolucent, radiopaque line, just at the tibial tuberosity. Should I go back? There you go.
Oh, that's the growth plate.
Yeah,
that's the growth plate. That's because it's the tibial crest that hasn't yet fused.
Actually, fused.
Yeah, so that fuses. So it's a normal anatomical feature. It fuses as the patient gets a little bit older. So that's what that is.
Another one from Laura, who's just a little bit too smart. Does Paddy see a link between X-ray severity and a dog being overweight?
I don't know. I necessarily do. I don't, to be perfectly honest, I don't know whether we as radiologists assess it in that way. I think patients that are overweight will certainly find it more difficult to manage because they're taking, particularly in forelimb lameness, because they're taking weight through their front legs and they've got more weight there for to take through their front legs. Yeah, but I don't know that I can say that I think that the weight increases the severity. I don't know, Hannah.
I think it's because we always talk about how there is strong clinical evidence that additional weight carriage not only affects the pain and the progression. And I think probably Laura's trying to say, do you see a dog that's in at 7 out of 9, 8 out of 9, they tend to have more grisly arthritic changes on X-ray. But I think, but an interview, we're beginning to see like phenotypic presentation, aren't we? Some dogs seem to lay down osteophytes and stuff quite readily, whereas other breeds potentially don't lay down such dramatic visual change.
Yeah, I don't know that we don't tend to see an awful lot of overweight dogs, would be one
Like
thing.
you.
Well, we don't. Mind you, maybe that's my assessment of what's overweight and what's not overweight.
They're just not
maybe there's a bit of self-denial going on there. But we don't tend to see vast amounts of overweight dogs. I think we've seen some dogs, like, for example, we've had a couple of Mastiff type breeds that get quite overweight, and they've had quite nasty signs. But I think actually the underlying condition in those dogs has been quite advanced anyway. And what I maybe would tend to see more is that I think they struggle more with managing their arthritis at that point. So yeah, I'm not sure if I've answered that question terribly well, Laura.
I think you have. I'm just going to use this quick gap between this and 10 top tips. I just want to do a big shout out, because I've seen a lot of the Canbasters are following this, and they are an absolutely amazing group of volunteers that, as I say, they oversee Holly's Army, which is our community group. It's very much there as an emotional as well as an educational support. So it's very much there for when you're having your moments of panic, when you're having your tears, when you're having your indecision, when everything feels wrong, no one's listening to you, you feel really isolated. It's a community group with very much that intention, as well as advice and education. They've started something which I think Paddy's going to be so impressed with. They've started a new thing called #DearHolly. So it's called Holly's Army, and it's a kind of agony aunt post where we had noticed that a lot of people were coming to the group, and we were worried that the advice given was going to be taken the wrong way, because maybe the dog was carrying a lot of weight, and they put a lovely photo of them and their precious dog, and the first advice that we feel to give them, which is free of charge, really imperative, is weight loss. And that's the first thing an owner would hear, is going to obviously make them feel this isn't a very friendly group. So we were very, very aware that we wanted to make sure that we could give advice in a non-emotive way. So we decided that we were going to create fictional characters. So Dear Holly is cases that the Canbasters, mainly Laura, Lynn and Hannah, I believe it is, make sure I've got that right, they create a case very similar to something that we've seen recently, and they encourage people within the community group to comment, knowing that they'll never offend, because it doesn't really exist. So that's for us to try and help people, instead of just being vicarious observers where you kind of listening, learning a little bit by little bit. Actually discussing means that you're going to be more confident in what you see and what you think, and you're therefore going to become the next wave of people to help other owners. And that's what we're trying to do. We're trying to be quite clever. We're trying to create a wave of learning. We're trying to create a wave of awareness, a bit like pyramid selling. The more people we can influence, they can then tell 10 people, and they can tell 10 people, they can tell 10 people. Sound like the COVID crisis, don't I? But yeah, so there's a new,
but a bit more positive.
There's a new thing that's going on, and Rosemary, I apologise, Rosemary, on Holly's Army, and I can't tell you how much time and energy and love these people put into making sure that Holly's Army stays safe and evidence-based. So we are really, really aware that there's a lot of rubbish out there, guys, and we're trying to protect you from that and sticking to what we know works, and letting you know when there isn't evidence for something. So there you go. Right, 10 top tips, very quick, because you've been here for 98 minutes.
98 minutes? I'm so sorry. Oh my goodness, I'm so sorry.
I'm amazed at you. You're
so sorry.
Don't be sorry. Do you know what? This has been beautiful. Beautiful. So perfectly worded and flowed and not stressful. I feel very calm for 98 minutes. So I'm going to start with
sorry. I feel dreadful.
Don't be. They're all having their gin and tonics watching, so it's fine. Right. So I'm going to start with tip number 10. And having just spoken about it, wait. We say it every time. And my phrase take your eyeballs out, put them back in, and look at your dog as if it's not your own works, because we handed out an owner questionnaire to somebody over in New Zealand that had come to one of my talks, and in the questionnaire the owner writes, yes, my dog's body condition score is at 6 out of 9. Yes, I did take my eyeballs out, put them back in, and be honest with myself. So it works all the way from over the pond. So weight control, guys, be cruel to be kind, especially with yourself. Number 9 for you.
Me?
Yes,
No.
you got with a 9. A tip.
A tip for sorry, I'm being a bit dense now. A tip for owners, for their dogs with arthritis.
Yeah.
Well, I have a dog with arthritis, actually. And I think, yeah, I think I would say, I think exercise, I think controlled exercise is still really important. And so I think it's really important that they still, for their mental, for themselves mentally, but also for the joints itself, it's really important that they continue to exercise. Actually, and my spaniel is arthritic. She's got bilateral elbow issues, and she still does a lot. And there's some days she's a little bit worse afterwards, and then I just manage that with making sure that she's kept comfortable. But she loves to get out and about.
Yeah, totally. I think we're becoming much more aware about mobility is necessary for physical and mental health. I'm going to to that to keep them moving. Don't be scared of pain relief. There's been a big flurry of people coming into the CAM world recently, always saying, I don't want to put him on medication, or I want to put him on long-term medication, or I'm scared to be reliant on medication. I'm going to be outrageous. Please consider them. They live in the now. They're feeling that pain. And they don't sit there going, oh, I really don't want to be on medication long term. I just want to feel better now. And please don't be in fear of using it with the intention to come off of it. But I have definitely found in my career many people that once they have pain relief on board realise how much of a life their dog gets back because of it. Then they can aspire to achieve that level with other interventions and phase away the medication. Please don't be scared of it. Number, oh my God, 7.
Oh no, 8. Is it 8?
No, 7. I'm at the
7.
Odds.
I'm 7. Okay. So the other tip I would have is that I think if you are concerned about your dog's lameness and whether you think things have changed, then I think it's important to go back and have a conversation with your vet. It's really important that you've got a very good open channel relationship, because I think, for them and for you, it's really important that they're aware of how things have changed, because they obviously won't know if things change at home, and that you feel you can go in and talk to them, because they'll want to make sure that they can do everything to make your pet more comfortable.
Yeah, I think I'll add to that with number 6 is that please provide us with some detail. So currently we're doing a lot of phone triage because of the COVID crisis. We're still only seeing emergencies, which is at the vet discretion of what is an emergency. Now I'm going to be very different. If I have somebody phone me and say, yeah, he's been a bit lame recently, then I'll be thinking, oh, okay, recently suggests acute, short term. I can manage this remotely. But if somebody said to me, he's been lame now and it's not changing, if anything, it's worsening, and it's been a good 3 weeks of him showing discomfort, I'm going to think very differently. So please work with your vet with some detail, because current climate, we really are having to work more together to make sure that we care for our dogs. Number 5 for you.
Oh, Hannah.
Oh, there's Luna's toy. And here she comes.
Number 5. What else do we do with our lame spaniel?
Don't let him jump in and out of the car.
Yeah, don't let them jump in and out of the car. That's true. The other thing I think for our spaniel particularly is try and not to allow them to hare up the stairs. She tends to go not even so much up the stairs and stuff, but she goes down the stairs you know, head first 100 miles an hour, and that bothers me with her elbows. And she has screws in because she had fissures. So I'm always delighted that our screws in her elbows, because at least they're not going to fall apart. She hurtles down the stairs.
It is really difficult because you're trying to let them have a normal life without, you know, ruining it by restricting them. But yeah, I think impact force. Number 4, you've only got 3 and 1 to think of, so you just put some background thinking up to number 4. Got quite a lot of practice at this. Number 4, I think current climate with the restrictions, I am spending a lot of time advising people by phone about how to keep them mobile in the home. So people think about exercising has to involve a harness, a lead, a leaving of the house, of going down the road or getting in the car and going to a park. It doesn't. Even if you've got a postage stamp garden, you can still do a lot of mobility focused activities. And that might involve some scatter feeding, it might involve hide and seek, it might involve, you know, some therapeutic exercises. You know, I used to put Holly's food in a Kong and watch her moving, low impact brain work as well. So number 3.
Now, I don't know if I'm allowed to say this or not, but what we tend to do to stop them with their kind of obesity or getting overweight, ours love carrots. So for treats, I often give mine carrots. And in fact, if you go to the fridge, they often ask. Now, when you go to the fridge, they'll often talk to me and say they want their carrot. Well, obviously, don't say that.
Talk to you.
They talk to me. In doggy language. Now, they'll often shout from the other end of the kitchen as when you come out of the fridge empty-handed. So ours love carrots, actually. So that's often a really good way to help supplement things, and they feel they've got treats, but yet you're not giving them bucket loads of calories.
There is a video that I will share. Well, I'll get Crystal to share. One of her clients created a kind of hungry hippo type game where she's got a cardboard box, loads of holes in it, and her hand is underneath it. And this carrot keeps popping up different holes. So the dog's like trying to get to the carrot. It's so cute. It's so fantastic. People are being really creative because they are isolating and being I'll remember to share that with you guys. It's wonderful. Number 2 is a very practical thing. You know, CAM has been going now since 2016, and there's an amazing workforce behind it, and I can't thank them enough. They're an amazing group of people, and we're growing. We are growing. Our intention is to try and make more people aware about the signs of pain, understand pain, and therefore be able to act on it, because that is the main clinical sign of arthritis, is pain. What we need is your help, and you need to spread the word. You need to talk to your friends, your dog colleagues, your dog groups, your agility clubs. We need to be talking about this. So these resources take quite a long time to make. Please share them. Please let other people know that they exist so we can help more people. Number 1.
Very simple. For your arthritic patients, give them all a huge hug from me.
Oh, I love it. That's so powerful, though.
Oh, they need the contact. Yeah, it's interesting. One of ours, we have a little Norfolk who's so needs contact lots of the time. She's really interesting. You know, the others are less bothered by it, but she has to be there.
Luna's very tactile, as you can see. She everything will fall off my carefully balanced desk. That gives me a really good point for nurses. I just want to big up one of our CAM team members that's been working stupidly hard on the front line. So Lindsay Tyndall has been working at New Priory stupidly hard, and I can always remember the day that she texted me and said, I want to do more for arthritis. I've spent half an hour massaging a dog in a kennel that's hospitalized for pancreatitis, but you can tell that he's got lots and lots of other musculoskeletal problems, and the difference it made to that. And it got the dog eating, and the whole kind of emotional state of that dog improved. So please don't dismiss the importance of tactility and time. Paddy, you're amazing.
Hard. I feel dreadful that I've kept you all so long on a sunny Sunday.
I don't think so. And everybody absolutely adores you. They think that you're amazing because
That's very sweet of you.
You are dedicated and really, really care about what you do, which is fantastic. So we're going to say goodbye. All the lovely messages to the lovely Paddy, please put them on. Even if you're watching a recorded version of this, please put lovely messages down, because it's always great to keep us going. Thank you, Paddy. I'm going to say
You're very welcome, Hannah. Thank you. Bye, everybody.
See you later.
Bye.